next is hyperkalemia, and that's a potassium higher than 5. So remember, most of your potassium is inside of your cells, whereas most of your sodium is in your intravascular fluids. So some causes of hyperkalemia are things like increased potassium intake, or cell disruption, or that then releases the potassium inside the cell into our vascular space, which will cause a sharp increase in our potassium. Include burns, necrosis, anything that would destroy cells themselves. Of course, decreased excretion, acidosis, and addisons. Signs and symptoms to remember hyperkalemia: think murder. M for muscle weakness, U for urine output low, R for respiratory distress, D for decreased cardiac contractility, E for EKG changes like peaked T waves, and R for reflexes decreased. Treatments for hyperkalemia depend on patient stability. If your patient's stable, we may give things like Lasix or Kxlate, and that pulls the excretion of potassium straight out of the body and gets rid of it. If your patient's unstable, having EKG changes, altered mental status, we may give things like insulin D50, albuterol nubs, calcium, and sodium bicarb to buy us time until we can get and fix that potassium level through things like hemodialysis. Now remember, your insulin and D50, your insulin only shifts the potassium into the cells, and D50 is to replace glucose lost by giving the patient insulin. But this is only a band-aid. One thing to look at when your potassium level comes back sharply elevated and there's been no change to the patient is to verify if the sample was hemolyzed. Hemolyzed samples can falsely elevate potassium levels. And if your patient's stable, we may need to ask for a redraw just to verify that that lab is correct and not due to the hemolysis of the cells.